picture this scenario for a second. You're sitting in a school counselor's office, and it's exactly 1 p.m. on a Tuesday.
Right, setting the scene.
Yeah, exactly. So the fluorescent lights are humming, the bell is about to ring for the next period, and sitting across from you is a student.
Okay.
And they're in an active crisis. This isn't some, hypothetical case study from a textbook. It's real, it's urgent.
Oh, absolutely. It's happening right in front of you.
Right. And the teenager sitting in that chair has finally, after probably months of just silent struggle, mustered up the courage to say 3 words: I need help.
Which is such a huge hurdle to overcome.
It really is. So the most important question in that room right then isn't actually diagnosing what's wrong. I mean, the most important question is how long before that student is actually sitting in front of a licensed therapist.
Yeah, and for the vast majority of public schools across the country, if we're looking at the raw operational data, the answer to that question is measured in weeks.
Wow.
Sometimes months, honestly.
Which is exactly why today we are taking a deep dive into a stack of programmatic overviews, outcome metrics, and operational guidelines from a Georgia-based model called MentalSpace School.
It's a really fascinating set of materials.
It is. Our mission here is to sort of deconstruct this systemic overhaul. We want to look at the actual mechanics of how you take a school's mental health apparatus, which, let's be honest, is traditionally built as just a reactive wait list, and physically, structurally, transform it into a proactive wellness system.
And that is a massive structural distinction. The sources we're unpacking today, they aren't just about offering therapy to kids.
Right.
They're actually a case study in redesigning the entire delivery mechanism of healthcare itself.
I mean, it's huge.
Yeah, we're exploring the operational friction between a system that manages a queue and a system that actually manages care.
Okay, so let's unpack this with a parallel. Imagine you fall and break your leg, right? Ouch. Yeah. You call an ambulance, and the dispatcher on the phone says, all right, we hear you, we validate your pain, we've got you in the system, and we will be there in 2 weeks.
You'd hang up immediately.
Right. In physical health, that's absurd. You would assume it was a prank, and you'd probably call the local news. But in school, mental health, that 2-week delay isn't a failure of the system.
No, not at all.
That is just standard operating procedure.
It is. It's the universally accepted reality of how the machinery currently works.
Yeah.
And to understand how a model like MentalSpace School is attempting to fix this, we really have to look closely at the timeline of a crisis.
Okay, let's do that.
We have to ask why the traditional model fundamentally fails students at the exact moment when they're at their most vulnerable.
So let's go back to that 1 p.m. on a Tuesday scenario.
Yeah.
In a standard setup, that student in the counselor's office is basically told, we hear you, we see you, let's get you on the list. But the documentation we have today contrasts this standard wait time of weeks with the MentalSpace model.
Yeah.
And they promise a connection, quote, same day, and in some cases, within the hour.
Yeah, and that brings us to the core thesis we pulled from these materials.
What's that?
Well, the defining line between a wait list and a functioning wellness system basically boils down to one incredibly underrated metric.
Okay.
It's the literal ticking clock time from the moment a student asks for help to the moment they're engaged in a clinical session.
Right.
The standard experience for most schools, as the documentation notes, is this grueling stretch of days or weeks. MentalSpace is trying to compress that entire timeline into hours.
I have to pause you right there, though, because I need to play devil's advocate for a second.
Sure, go ahead.
Same-day therapy sounds absolutely incredible on a glossy brochure. I mean, it sounds great.
Oh, for sure.
But practically speaking, when they say same day, is that actually a full, meaningful therapy session? Or are we talking about like a glorified 15-minute triage phone call just so the school can check a liability box and say, yep, we responded?
Well, that is exactly the right question to ask, because triage is not therapy.
Right.
If it were just risk assessment, checking to see if the student is an immediate danger to themselves and then just sending them back to class, it wouldn't be a systemic solution.
It would just be a slightly faster waiting room.
Exactly.
Yeah.
But the sources outline that delivering a meaningful 45 to 50-minute clinical session on the same day actually requires bypassing a massive wall of administrative red tape.
Okay, how so?
MentalSpace utilizes same-day teletherapy to make the connection happen, but the video software is really only half the equation here.
And the other half?
The other half, the part that actually makes it work, is their backstage operations.
Which means we need to look at what is actually causing that massive traditional delay. I want to trace the anatomy of a bottleneck here.
Let's do it.
If a student asks for help on Tuesday, what is the sequence of doom that pushes their care out by 14 days?
Well, it's essentially a cascade of administrative friction.
Okay.
First, you have insurance verification, which usually involves a school social worker playing endless phone tag with an insurance provider.
Ugh, the worst.
Right. Then you have the intake forms that physically need to be sent home, signed by a parent or guardian, and then brought back.
If they don't get lost in a backpack.
Exactly. And after that, you have scheduling friction. You're trying to magically align a student's open elective period with a community therapist's single open slot.
Sounds impossible.
It often is.
Yeah.
And finally, you have network availability. I mean, is there even a child psychologist in your zip code who is actually taking new patients this month?
I mean, it's like hitting a series of administrative toll booths while you're rushing to the ER with that broken leg we talked about.
That's a great way to put it.
You have an emergency, but the system forces you to stop, turn off the engine, and literally find exact change every single mile.
And what's fascinating here is, deeply concerning from a clinical perspective, is the psychological cost of those toll booths.
The weight itself does damage.
Exactly. The documentation specifically highlights a concept called the moment of openness.
Oh, I saw that. Let's dig into that.
It's crucial. When a teenager or even their family finally reaches out for help, they are in a highly elevated state of vulnerability.
Right.
They're desperate, yes, but they're also open to intervention.
Armor is down.
Exactly. The armor is down. But when the system hits them with a 20-page clipboard of intake forms and a 2-week scheduling delay,
Yeah.
by the time that appointment finally rolls around, that crucial psychological window has closed. The moment of openness has passed.
They just give up.
Basically. The family has retreated back into their shell, trying to manage the crisis entirely alone. They harden up again just to survive the wait.
So how does this new model actually bypass that? Because the documentation says MentalSpace conducts the clinical intake during the first session, rather than using the intake paperwork as a blocker to prevent the first session from happening.
Right.
But I need to push back on the mechanics of that. I mean,
Yeah.
anyone who has ever dealt with American healthcare knows intake requires insurance verification and demographic data.
Oh, absolutely.
If you were doing that live on a Tuesday afternoon while a student is crying in a counselor's office, doesn't that just turn the therapist into a billing agent?
Well, if the therapists were doing it alone, absolutely. And that's where the operational redesign comes in.
Okay, walk me through it.
The documentation details that while the licensed clinician is building rapport and doing the verbal clinical intake with the student over teletherapy,
Yeah.
a dedicated administrative team in the background is running the instant insurance verification and handling the compliance paperwork with the parents.
Oh, wow. So they
Yeah.
split the job.
Exactly. They are completely decoupling the clinical care from the administrative processing. They run simultaneously rather than sequentially.
Okay, that makes sense. They're taking the paperwork completely out of the doorway.
Huh.
But, and here's the catch, removing the administrative red tape gets the student in the virtual door on day one,
Right.
which creates a new, terrifying problem for the school system. If you suddenly make access easy, you are going to uncover a massive wave of hidden demand.
Oh, for sure. The floodgates open.
Yeah. So how does a school practically handle that volume without the system immediately crashing?
Well, this leads directly into what the sources describe as the 3 critical tests of a school mental health system.
Okay, what are the tests?
The materials argue that most traditional, well-intentioned partnerships fail at least one of these 3 tests: speed, capacity, and cultural fit.
Okay, we just spend time on speed. In 2 winks is fundamentally too late.
Right.
But let's look at capacity. The sources point out a startling reality. Having one contracted therapist for a school of 1,200 students is not a system.
No, it's not.
It's just a bottleneck disguised as a solution.
It's a mathematical impossibility. If one therapist is responsible for 1,200 students, they can only ever be reacting to the most severe 5-alarm emergencies.
Right, the kid's in immediate danger.
Exactly. Everyone else, the kids with emerging anxiety, the kids experiencing early depressive symptoms, they're just left languishing on a wait list until their symptoms escalate into a full-blown crisis.
Which is terrible.
It is. MentalSpace approaches this by utilizing dedicated therapist teams for each school, rather than relying on a single solo contractor.
I keep getting stuck on the math here, though. 1,200 kids to one therapist. Even if you clone that therapist, the math still fails.
Right, the numbers are daunting.
So how does a school realistically conjure an entire dedicated team of professionals out of a standard, perpetually underfunded public school budget. Are we just assuming these schools suddenly have infinite money?
I know it's so easy to assume this is purely a funding issue, but the sources argue it's actually structural failure in how care is sourced.
What do you mean?
Well, when a school relies on an in-person local contractor, they are limited by the physical geography of who can actually drive to the school building on a Tuesday morning.
Right, the local talent pool.
Exactly. But by utilizing teletherapy and a team-based approach, you decouple the therapist from the geography. You can pool resources across an entire state's network of clinicians.
Oh, I see.
Yeah, you aren't hiring one full-time local body. You are tapping into a scalable grid of availability.
Which totally solves the math problem of capacity.
It does. But, simply having enough available bodies on a screen isn't enough to make therapy actually work.
Fair point.
And that brings us to the third and arguably most complex test, cultural fit.
Right. The sources are very explicit about this. MentalSpace uses licensed, diverse, culturally competent clinicians.
They do.
And they state pretty bluntly that therapists who don't reflect the community they are serving lose trust before that first session even ends.
Cultural fit is one of those terms that gets thrown around like a corporate buzzword.
Totally. It's everywhere.
But in clinical mental health, it's a biological and psychological imperative.
Really? How so?
Well, think about the mechanism of therapy. Trust is the absolute foundation.
Obviously.
If a student sits down with a therapist, even if they got that appointment on the exact same day they asked for it, and they feel entirely misunderstood by someone who doesn't understand their background, their neighborhood, or their lived experience,
It's not going to work.
exactly. The therapy itself is clinically ineffective.
Because the student spends the whole session translating their life instead of actually processing their trauma.
Yeah, that is exactly it. And the stakes are incredibly high. If there is a massive cultural disconnect, you don't just have a slightly unproductive session.
What happens?
You have a teenager who concludes, therapy doesn't work for people like me, and they might never ask for help again. They retreat from the medical system entirely.
Wow. That's a chilling thought.
So when a program insists on diverse, culturally competent clinicians who actually reflect the student body, they aren't just checking a demographic box for a brochure. They are actively lowering the barrier to clinical efficacy.
Okay, so that's structural redesign, focusing on the speed of intake, expanding the actual capacity through these pooled teleteams, and insisting on diverse cultural fit. It has to create a massive ripple effect on the entire school ecosystem.
Oh, the ripple effects are huge.
Because you aren't just helping one kid at that point, you are changing the environment. Which brings us to the hard data. I want to look at the actual outcomes reported here, and frankly, I want to know how families actually pay for this.
Well, first, let's look at the breadth of care outlined in the sources.
Okay.
Because they've expanded capacity, they aren't just doing one-on-one triage for severe anxiety. The system handles crisis intervention, yes, but it also covers suicide and violence prevention, family counseling, and even staff wellness for the teachers who are burning out.
Which makes total sense. I mean, if the system is truly proactive, you aren't just running around putting out fires, right?
Yeah.
You are fireproofing the building.
That's a great analogy.
You're supporting the adults who support the kids. But the numbers that jump out from the outcome metrics in these sources are just staggering.
They really are.
They report an 85% family satisfaction rate, which is great. But then you have 92% reduced anxiety.
Yeah.
And right next to it, deeply connected, is 89% improved attendance.
So if we look at the underlying mechanics here, those two numbers, the 92% reduced anxiety and the 89% improved attendance, they're intimately linked.
Really? How?
Well, one is a clinical metric and the other is an administrative metric. Traditional school systems often treat attendance as just a disciplinary issue.
Right. A kid isn't showing up, so they get detention. Or the parents get a threatening letter from a truant officer.
Exactly. But chronic absenteeism is very frequently a direct symptom of untreated anxiety.
Explain the mechanism there. Why does anxiety automatically equal an empty desk?
Well, think about what severe anxiety actually does to a teenager's nervous system. It triggers a literal fight or flight response. For a student with intense social anxiety or trauma, the school building itself, the crowded cafeteria, the loud hallways, it literally becomes the trigger.
Oh, wow.
Their brain is treating the classroom like an actual threat to their survival, so they don't skip school because they're defiant or they don't want to learn.
Right.
They skip school because their nervous system is forcing them to avoid a perceived threat.
That makes so much sense.
Therefore, solving the underlying anxiety organically solves the attendance problem.
I love that framing. It's like realizing that replacing the engine, which is the student's mental health, automatically fixes the speedometer, which is their attendance.
That is a perfect analogy.
You don't fix a broken speedometer by tapping angrily on the glass or giving the dashboard a detention. You open the hood and fix the engine.
Right. When you solve the mental health bottleneck, you are fundamentally repairing academic engagement.
Yeah.
You are removing the invisible psychological barrier that was keeping that student out of the classroom.
Okay, but we have to talk about the elephant in the room here.
Which is?
The reality of accessibility and funding.
Ah, yes. Always a big question.
Because all of this,
Mm-hmm.
instant insurance verification, dedicated teleteams, same-day care, it sounds incredibly expensive. How does this not bankrupt a family?
Well, the sources detail the funding model pretty clearly, actually.
Right.
They note that they accept major commercial insurances. They don't just take one obscure provider. They integrate with the big ones, BCBS, Cigna, Aetna, Humana, and so on.
Right.
But the crucial detail, the real game changer here, is how they handle Medicaid.
Okay, what do they do?
That is the linchpin of the whole model.
Mm-hmm.
By setting up the vast infrastructure to accept that wide range of commercial insurance, they make it accessible to the middle class.
Sure.
But specifically ensuring that Medicaid is accepted with $0 out of pocket entirely removes the financial toll booth for the most vulnerable families in the district.
Wow. It's democratizing access. You are taking a premium concierge-level response time, seeing a therapist the same day, and making it available to a student regardless of their parents' tax bracket.
Exactly.
And then on the flip side, you have the school's administrative burden. The model is HIPAA and FERPA compliant, naturally.
Of course.
But the documentation specifically highlights how this helps Georgia schools meet an upcoming, very real deadline. The HB 268 compliance deadline hitting in July 2026.
Yes. And for anyone listening outside of Georgia, you really need to understand the mechanism of laws like this.
Because they're everywhere.
Yeah, they are sweeping the country. State legislatures are increasingly mandating that public schools must have specific, robust mental health safety nets in place.
Wow.
They are essentially turning schools into frontline healthcare providers overnight, ready or not.
That's a massive shift.
It is. And programs like MentalSpace, and the materials explicitly note school administrators can reach them at mentalspaceschool.com or mentalspaceschool@chictherapy.com, are designed to make schools legally and clinically compliant with these state mandates.
And it does that without forcing the high school principal to suddenly become an expert in psychiatric deployment, right?
Exactly. They offload the massive structural burden to the actual specialists.
Which is how it should be.
Precisely. The school educators can go back to educating, knowing the healthcare logistics are being managed by healthcare professionals.
So let's pull all of this together and sort of review the journey we've just taken through these sources.
Sounds good.
We started by looking at the traditional, just agonizing 14-day wait list, a broken system where a student finally asks for help and they're immediately handed a stack of paperwork and a 2-week waiting period.
Completely squandering that fragile moment of openness.
Right. And we contrasted that failure with the mechanics of a rapid response, same-day wellness system.
Yeah, we explored how integrating teletherapy bypasses geographic limits to solve the capacity problem.
We looked at why deploying dedicated, culturally diverse teams is a clinical necessity, not just a preference.
And we saw how performing instant, simultaneous administrative intake captures the student exactly when their armor is down.
It is a complete paradigm shift in how we think about care delivery. And for you listening to this right now, whether you're a school superintendent staring down the barrel of that July 2026 compliance mandate, or you're a parent who has spent countless frustrating hours navigating the absolute maze of pediatric healthcare, or you're simply someone fascinated by how we deconstruct and solve deeply entrenched systemic problems, this matters.
It really does.
It matters because it proves that the bottleneck is a choice. We do not have to accept a 2-week wait as an unchangeable law of physics.
That is the ultimate takeaway here. The operational mechanics of care delivery are just as important as the clinical care itself. By fundamentally restructuring how we process a student's intake, how we deploy our clinical teams, and how we navigate the funding to remove out-of-pocket costs, we can actually align the healthcare system with human psychology.
Wow.
We
Yes.
no longer have to force human psychology to wait on administrative convenience.
Which leaves us with one final idea to chew on, building on that crucial concept of the moment of openness we talked about.
I'm intrigued.
If MentalSpace and programs like it successfully normalize this kind of proactive, same-day, culturally competent mental health care for K-12 students,
Yeah.
how is that going to fundamentally alter this entire generation's expectations of the adult healthcare system?
Oh, that's a brilliant question.
Right. But think about the long-term ripple effect. Will a generation raised on rapid response care, a generation that intrinsically knows help is available the exact same day they ask for it, simply refuse to tolerate the traditional, agonizing 2-week wait list when they enter adulthood?
They probably will.
I mean, if you never had to wait 2 weeks for the ambulance for your broken leg, why would you ever accept waiting 2 weeks for your mind?